Hello and welcome everyone to tonight's webinar, the first in a series of 5 webinars on sleep, brought to you by Capital Health Network and sleep experts in the ACT. Tonight's webinar focuses on sleep investigations. The second webinar is scheduled for February 2024 and will cover insomnia. And the other 3 webinars will be listed on the Capital Health Network website. So have a look at the website calendar for upcoming events. First, I would like to acknowledge the traditional custodians of the land we are meeting on. I acknowledge and respect their enduring culture and the contribution they make to the life of this city and this region, and I pay my respects to their elders, past, present, and emerging. I also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending today's events. Their land was and has never been ceded. I am Dr. Leonie Harcourt, a GP advisor at the Capital Health Network. Also with me tonight are sleep specialists, Dr. Meera Srinivasan and Dr. Carol Huang, and of course, Kunal Mohiti, the events lead at Capital Health Network. So housekeeping, all participants have been muted. Please address any questions you have into the Q&A section on your Zoom panel, not the chat box. And we will have a question and answer session after both Meera and Carol have presented. The presentation itself will be uploaded to the Capital Health Network YouTube page, and you are welcome to share it with your networks. With respect to CPD, please fill out the post-evaluation survey. We do look at them and use them to kind of develop future events for you. CHN will email you a certificate of attendance, and please feel free to report 1.5 hours of educational activities to your CPD home. Before we start, I'd like to highlight the Health Pathways website. So the login is together, so all lowercase and the word together. And the password is for health, all lowercase, and that's FORHEALTH. So there's quite a few sleep resources on the Health Pathways website, and we're going to update them soon to keep them contemporary with referral pathways and clinical information. Our first presenter tonight is Dr. Meera Srinivasan. Meera is a respiratory and sleep physician and works as a staff specialist at the Canberra Hospital. Meera previously worked as a staff specialist at Royal North Shore Hospital in Sydney. She has an interest in airways disease and is currently completing a PhD in respiratory physiology at the Woolcock Institute of Medical Research. So over to you, Meera. Thank you very much.
Thanks, Leonie, and thanks for that introduction. So today I'll be talking about taking a sleep-focused history and forming a differential diagnosis for sleepiness. At the end of this talk, I hope that you'll have a bit of an understanding of how to form a differential diagnosis for daytime sleepiness, to be able to take a targeted history to differentiate causes of sleepiness, and to understand the relevant clinical examination finding and baseline investigations in patients presenting with sleepiness. And we will discuss briefly the driving guidelines pertaining to some sleep disorders. So I'm sure that many of you out there, similar to me as a sleep physician, get a patient coming in the room and saying, I'm just tired, I'm sleepy, and it is a little bit of a heart sink moment, but it's extremely common. And as I'm sure many of you know, has a very broad differential and is often multifactorial. Sometimes differentiating between the specific clinical presentation, so whether it be excessive daytime sleepiness or fatigue, can be helpful in teasing out the differential diagnosis in this condition. But it does have a very, very broad differential diagnosis. And just to outline sort of my thought process when a patient presents with sleepiness or daytime fatigue, a really common presentation, and I think an increasingly common presentation in today's society, is just inadequate sleep quantity. So not enough time spent in bed, people burning the candle at each end and trying to fit too many things into their lives. But also things like sleep onset insomnia or sleep maintenance insomnia. So difficulty getting to sleep and then waking during the night, and fitting into that is problems with sleep hygiene. Obviously, sleep disorders can contribute towards daytime sleepiness, and that can be obstructive sleep apnea, restless legs, and we'll touch briefly on these less common conditions like idiopathic hypersomnolence and narcolepsy. Medical conditions, and there's an extensive list, and I sort of think about them as whether they can have a direct impact on the sleep quantity and quality themselves. So things like nocturnal pain from arthritic conditions, nocturia from benign prostatic hypertrophy or diabetes, impacting on sleep quantity and quality, or fatigue as a symptom of the condition itself. And then obviously patients might present with acute or chronic symptoms due to those conditions. So post-viral fatigue or post-viral sleepiness is extremely common, and certainly much less of a worry than a more chronic presentation. Psychiatric presentations, and sometimes I've seen patients present with sleepiness or fatigue as the first symptom or the predominant symptom of suggesting that their depression is control is deteriorating, or the first symptom of a major depressive episode. Medications, including over-the-counter medications and substances. So huge differential diagnosis here, and many patients will have more than one of these symptoms at play. So even if they do have an underlying sleep disorder, there are certainly other things that could potentially be addressed in the primary care world prior to their referral to a sleep physician, or at the same time, to try and target these issues together. So in terms of approaching a sleep history, I find that asking a few quite open-ended questions is really helpful because it gives you a really overall assessment of a number of things. So I tend to just ask them a few questions like, what time do you go to bed? Like, what time do you put yourself to bed of a night time? And how long does it take you to fall asleep? Do you fall asleep quickly, or does it take hours? And what time do you wake up in the morning, and what time do you get yourself out of bed? And then I get sort of an understanding from them about what their concept of their own subjective sleep quality is. So do you feel like you wake up many times during the night? If so, what wakes you? And if you do wake up, do you fall back to sleep easily? And those sort of 5 or 6 questions gives me a really good understanding of what is their sleep quantity? Are they getting enough hours of sleep, or are they putting themselves in bed for enough hours to expect a reasonable amount of sleep? What's their assessment of their own subjective sleep quality? Do they suffer from sleep onset or sleep maintenance insomnia? Are there medical conditions at play that might be waking them from sleep? Things like pain, nocturia, anxiety. And it also gives you really good assessment of their sleep hygiene. So if they really can't answer these questions because they go to bed at a really varied time every night, so some nights it's 9, some nights it's 12, they can't tell you whether some days they wake up at 6 a.m., some days they wake up at 10. It gives you an idea that maybe they're just not really, their sleep hygiene is a bit all over the place, and that may be affecting their ability to fall asleep and obtain good sleep quantity and quality. I think this is really important, and it is quite helpful to me to keep in my mind to reassure patients, and also to really hone into them that you will be sleepy if you don't sleep for enough hours at night. And so the Australian Sleep Health Foundation recommends 7 to 9 hours of sleep per night for adults. And the Australian Institute of Health and Welfare reported that in 2021, that 20% of adults between the ages of 35 and 44 were reporting less than 6 hours of sleep per night. And you can see on this graph here from the Centre of Disease Control that the number of, or the percentage of adults reporting inadequate sleep, so less than 6 hours or less of sleep, has significantly increased for all age groups between 1985 and 2004. And I think it's actually probably continued to increase now. The other thing that's really important to inform patients is that catch-up sleep is really insufficient to rectify a sleep debt, or you need excessive amounts of catch-up sleep to rectify a sleep debt. So, I hear a lot of patients saying they get sort of 5 to 6 hours of sleep during the week, but they make up for it on weekends. And the fact that extra 2 hours of sleep or 3 hours of sleep on a weekend is really not enough to make up that 5 or 6 hour sleep debt that they've accumulated during the week. And this study here in 2021 showed that when they partially sleep deprived patients for 10 days, even when they let them sleep as long as they wanted to for the 7 days after that, they still had their cognitive processing was below their own baseline. So they were still suffering the effects of that sleep debt 7 days later. And then it comes to some specific questions pertaining to sleep disorders. So obstructive sleep apnea, obviously very common, and will be a topic in and of itself in this webinar series. So I won't go into it in too much detail, but these questions are quite good screening questions for obstructive sleep apnea. So snoring is very sensitive in that most people with obstructive sleep apnea snore, but it's not at all specific in that many people snore and don't have sleep apnea. Witnessed apneas though, so a bed partner or a roommate hearing episodes where the patient stops breathing and then wakes up gasping for breath, or they've been admitted to hospital and have been told that they were sort of shaken awake at night, or their nurses noted that their oxygen saturation dropped overnight. That's much more specific for sleep apnea. Other questions that I find quite helpful are if the patient has managed a reasonable night's sleep by their standards, so they've gone to sleep, had a good sleep quantity, and they subjectively report that they had good sleep quality. So they didn't have insomnia, they felt that they slept well during the night, but they still never wake feeling refreshed, is often a suggestion that there might be something going on with the sleep quality, like something like obstructive sleep apnea. Morning headaches and dry mouth are often symptoms reported commonly as well. I'll just briefly touch on this because although rare, they are quite important to recognise as they are associated with quite significant risk to the patient. So narcolepsy syndromes are rare, is a group of rare neurological conditions causing really excessive daytime sleepiness, where essentially REM sleep intrudes into wakefulness. And the suggestive features on history are that really excessive daytime sleepiness, without really other features that would lead to a cause of sleepiness. So they don't have classic features of obstructive sleep apnea. They're getting good sleep quantity. They don't have a lot of other medical conditions. Often these patients are quite young. And then other suggestive features are this REM intrusion into wakefulness. So cataplexy, which is a feature of type 1 narcolepsy, is essentially where patients lose body tone. And it's that classic thing that you see in the movies where the patient sort of slumps to the floor and falls asleep while they're talking to you. Typically, it's triggered by a strong emotion. It's not always that dramatic, but those sleep attacks of cataplexy are really, really characteristic of type 1 narcolepsy. Other more subtle intrusions of REM sleep can be REM sleep paralysis. So the patient reports that they wake up from sleep, but their whole body is paralyzed. So they're still in REM sleep, but they're conscious. Hypnagogic and hypnopomnic hallucinations. So as they're falling asleep or as they're waking up, they see and hear things that they know aren't real. They're not true hallucinations. Or they report that they can fall asleep into naps really easily. And when they do, they fall into these really vivid dreams, which it can be suggested that they're falling right into a REM sleep cycle. I've got this video of Homer here because there's actually there's a whole Simpsons episode dedicated to Homer Simpson having type 1 narcolepsy. And as many things the Simpsons do, it's quite technically accurate in that they use a lot of the correct medical terminology and investigations to diagnose him. Idiopathic hypersomnolence is similar to narcolepsy, but without the cataplexy or the strong REM intrusions into sleep. But the classic symptom is this profound daytime sleepiness, despite really good sleep quantity, good sleep quality, absence of other medical or psychological causes. And in my experience, the patients that I suspect who have this are typically quite young, typically quite healthy, so not a lot of other comorbidities. They really are genuinely focused on their sleep hygiene. They're sleeping for 8 and 10 hours a night, but still having to nap during the day. And they've had this for a while. Some of them have a clear viral trigger and some of them have a bit of a waxing and waning course. But those sorts of patients may have this condition and often do respond really well to treatment. So I've covered a lot of this already, so I'll just sort of fly past it a bit. But in the general background history, the things that I sort of focus on are in the medical history, if there's anything else causing fatigue specifically, and again, teasing out that whether it's fatigue or sleepiness they're reporting. Are there any other medical conditions that are affecting the sleep quality? And do they have any medical problems that might be a complication of an underlying sleep disorder? So something like very poorly controlled hypertension with risk factors for obstructive sleep apnea would be really relevant to flag to a sleep physician. Do they have underlying anxiety and depression? And this is something I find that in my patient cohort, they don't tend to volunteer this unless they're really specifically probed about it. And they tend not to recognize sleep symptoms as being a potential side effect for their depression or anxiety. Medication, so both the compliance with their medication or potential side effects from a wide variety of medications, and then substance use or misuse. Now, I think Carol will talk in more detail about some of the scales that we use to assess sleep symptoms. But the Epworth Sleepiness Scale is quite a useful tool in assessing daytime sleepiness. So it's this 9-point scale that assesses the chance of dozing off or falling asleep in a variety of situations. But I often find while these scores are helpful, what's often more helpful is just asking some open-ended questions to try and assess whether the sleepiness is really excessive. So some people will come to me and say, oh, yeah, I'll often fall asleep at 5:30, 6 o'clock watching television. And really, that's not particularly excessive daytime sleepiness. So I often ask them things like, if you're watching something on television or reading something that's interesting to you, do you find yourself nodding off or falling asleep? Do you fall asleep when you're doing something important, like talking to somebody? Do you have difficulty at work or school, concentrating on lectures or concentrating on a task? Could you fall asleep in a meeting? I think those things are much more suggestive that the sleepiness is intrusive into somebody's life, rather than just, something that could happen to many people in the population. Driving is an important one to assess, obviously. So both patient and partner reported or family member reported microsleeps at the wheel, or certainly any motor vehicle accidents related to excessive sleepiness. Just very briefly touching on driving. So Austroads has quite a good resource here. Essentially, if you Google Austroads assessing fitness to drive, there are links for medical practitioners for a range of conditions, including sleep disorders. But I guess the key point for obstructive sleep apnea in particular is that it needs to be obstructive sleep apnea with associated symptoms. So that is excessive daytime sleepiness, or you as the physician are concerned that the patient is at risk of a microsleep behind the wheel, and that might be because of their symptoms, or because of partners reporting, or because they're having issues in their executive function in other aspects. And certainly a prior motor vehicle accident or a prior near miss would all be factors where you would not want this patient to have an unconditional license, and their license would be conditional on treatment of the condition. But simply having obstructive sleep apnea alone, and because we know that there's probably many, many people out there with obstructive sleep apnea who are undiagnosed but asymptomatic, is not enough to remove somebody's unconditional license. Narcolepsy, though, is another kettle of fish. And if narcolepsy is confirmed, then patients aren't fit to hold an unconditional license and need a sleep physician review and commencement on treatment before a conditional license can be granted. So if you have strong clinical grounds that a patient might have narcolepsy, I would really caution them to avoid driving or minimize driving as much as possible, because the risk is really high, and often patients have really no control over their sleepiness. So just on examination, apart from a general physical examination, mostly to exclude other potential causes of fatigue, things specifically that can help with assessing sleep are height, weight, and body mass index, as we know that increasing body mass index has an increase, is associated with an increased risk of obstructive sleep apnea, particularly patients who have a large, thick neck. So anything that puts extra pressure on the upper airway and reduces the caliber of that upper airway. Oxygen saturations, if you can do it, or the nurse in your practice can do it, is quite helpful, particularly in patients with morbid obesity, where you may be concerned not just about obstructive sleep apnea, but about obesity hyperventilation syndrome. So an increase in carbon dioxide leading to a reduction in oxygen saturation, or in patients with medical conditions that might put them at risk of respiratory failure. So things like neuromuscular conditions in particular. Heart rate and blood pressure is important. So poorly controlled blood pressure is a side effect of strongly associated with obstructive sleep apnea. And then examining the mouth and the craniofacial structures, looking for features that might put patients at an increased risk of that upper airway collapsibility. So up here is a picture of retrognathia. So the mandible sitting back behind, sitting back and reducing the passage in the oropharynx. It increases the risk of obstructive sleep apnea. Here you can see stages of tonsillar hypertrophy, with stage 3 and stage 4 tonsils certainly increasing the risk of sleep apnea. Macroglossia, so a large tongue, or a crowded oropharynx, looking at the Mallampati score, which is here on the next page. So class 3 and class 4 Mallampati airways are at a much higher risk of obstructive sleep apnea. So if you open their mouth, they've got a large tongue, you can't easily see the soft palate, or even at class 2 or class 3, but they've got really large tonsils. Those patients are certainly at increased risk. So I've just taken this from one of the guidelines in the Australian Family Practitioner about the assessment of fatigue. And I won't go through it in detail, because I think it's a lot of what we've discussed, and a lot of it is fairly straightforward, and I'm sure what most of you do in day-to-day practice anyway. So looking at red flag symptoms and assessing how long they've had symptoms for, et cetera, et cetera. I think there is a push away from broad sweeping investigations for patients presenting with fatigue, because certainly it's a small proportion of people who present with fatigue who have an obviously correctable abnormality like hypothyroidism or iron deficiency anemia. Having said that, my personal feeling is that if the fatigue or sleepiness is prolonged, so it's not clearly related to a viral illness that they've just recovered from 2 weeks ago, these and I haven't had these investigations recently, they're really low-hanging fruit. So they may not explain all of their fatigue or all of their sleepiness, but often these problems are chronic. They really have a huge impact on the patient's welfare. I think if there's something that we can correct easily, then it's definitely worthwhile assessing. So this guideline has suggested, if the fatigue persists, that they recommend these blood investigations here. So a full blood count, EUC, LFTs, maybe a CRP, a blood glucose, thyroid function, and ferritin. I would actually suggest that I would also do full iron studies, not just a ferritin, because as we know, ferritin can be inappropriate, can be normal, particularly in patients with underlying chronic diseases. I tend to at least check a B12 and folate at some stage. Again, it's very easily correctable, and I typically do a vitamin D as well. Again, this is adapted from the same article, looking at red flag symptoms for a serious underlying disorder. Again, many of these are really obvious, so things like abnormal bleeding, shortness of breath, or sudden onset severe fatigue in a previously well person. But other things that I would think of would be if there's any clinical signs or symptoms of hypoventilation. So as I mentioned, if they had underlying conditions of neuromuscular conditions, if they were very obese, if they had low oxygen saturations or an elevated bicarbonate on routine bloods, they would all be suggestive of hyperventilation and certainly prompts more urgent review than just a patient with pure obstructive sleep apnea. Any of those clinical features of narcolepsy are worthwhile thinking of as a red flag because it does put the patient at significantly higher risk. And then looking at other risk factors in terms of the morbidity of the patient and the public. So, for example, things like excessive daytime sleepiness in a patient that's a commercial driver or that works on a work site and might have to drive a forklift or has been in a car accident before that may have been related to a microsleep. So just very briefly, things that I think are useful to include in the referral, certainly the more information, the better. I'm sure many of you know that the wait times for investigations of sleep disorders in the public system is quite long, but we do try and triage the referrals and really try and prioritize those who need to be seen urgently. So particularly those with significant underlying comorbidities, things like pulmonary hypertension, very poorly controlled hypertension, so on multiple agents with the strong risk factors for obstructive sleep apnea, we would try and prioritize. If there were concerns about obesity hyperventilation syndrome or another type of hyperventilation, we'd certainly try and prioritize those patients. Or anyone with risk factors for narcolepsy or concerns about narcolepsy, we would try and prioritize. Similarly, if there was if commercial drivers had a significant risk of obstructive sleep apnea, we'll try and prioritize that. So including all those things in the referral really helps us to try and hone in on how we can help this patient and make sure that those that need to be seen urgently do get seen. And including those results of investigations is really helpful because often patients can't remember what they've had or where they've had them. And, we've just repeated everything only to find out that you guys have quite appropriately done the thyroid function 2 weeks ago. Just a few suggestions. As I said, often these patients do have multifactorial reasons for their sleepiness and fatigue. And I find sometimes, even while we're waiting for things like sleep studies and potentially treatment for obstructive sleep apnea, starting to treat some of the other things that can be contributing to their sleepiness can also help. So often they have sleep apnea, but they also have sleep onset or maintenance insomnia. So there are some good guidelines for sleep hygiene online. I find that This Way Up website a really good resource to direct patients to because it's free and they can work through it at their own pace with regards to their insomnia. And the Sleep Health Foundation has good general fact sheets about a range of sleep conditions. And as Leonie's already mentioned, the community health pathways, and there is a good resource there on obstructive sleep apnea. So just briefly to recap again, the take-home points for today are that excessive sleepiness and fatigue are incredibly common presentations and often hard to tease apart the multiple factors that can be contributing. But certainly I think just a lack of adequate sleep quantity is playing an increasing role in today's society, particularly among otherwise healthy, young and middle-aged people. Differentiating between sleepiness and fatigue can be useful in the history to be able to tease apart the exact cause, so whether it's more likely a side effect of medications or a medical condition causing fatigue rather than sleepiness per se. And taking a dedicated sleep history and examination can be helpful in its differential. Narcolepsy is rare, but important to recognise as it can have a huge impact on morbidity and occasionally mortality as well. And often these patients it's years between their original presentation before diagnosis. Investigations are not always required, and certainly in the guidelines there is this push away from doing broad investigations. But I think if you've got a patient who's had long-standing sleepiness or fatigue and they haven't had some of these baseline investigations, it's low-hanging fruit. It's worthwhile ruling out. And the more detail in the referral, the better, to allow us to appropriately triage and expedite urgent reviews. And that's all. So I think we'll leave questions to the end because many of the questions may be covered in Carol's talk actually. But I'm happy for you to type in on the Q&A as well. And otherwise we can answer at the end.
That was really great. Thanks, Meera. And I'd like to second that about the resources that Meera presented. This Way Up is a great website because it also, not only does it have insomnia programs, but it's also got many mental health programs that are very affordable and accessible for patients as well. And the community health pathway is free. So that's really useful for GPs and for other primary care providers. So on to our second speaker. So our second speaker is Dr. Carol Huang. You might remember Carol from our obesity webinar series. She was a major driver for that, and we thank her very much for that. Carol is a respiratory sleep medicine and general internal medicine physician and works as the Director of Respiratory and Sleep Medicine at the Canberra Hospital and also privately at RSCM, where she consults on sleep and obesity medication. She's the first staff specialist in sleep medicine employed by the Canberra Health Services and has been practicing in Canberra since 2007. She's also worked as the lead physician in the Canberra Obesity Management Service for 6.5 years prior to returning to Canberra Hospital full-time as the Director of Respiratory and Sleep Medicine. Her main research interests are medical obesity management, non-invasive ventilation, CPAP acclimatization, and pulmonary physiology. Carol also has scope certification from the World Obesity Society. Carol will be talking about the investigations used in sleep medicine and how they can aid the diagnosis of sleep disorders. And yeah, please put your questions in the Q&A box and we will do the Q&A section at the end of the presentation. So thank you very much, Carol.
Thank you, Leonie, for the kind introduction. So today my task is to tell you a little bit about the investigations, some of which we use in sleep medicine and some of which you can actually use in your consulting room also. So the learning objectives of today's talk is to hopefully by the end of this talk, you'll be able to discuss the differences between Epworth Sleepiness Scale and OSA screening questionnaires, and also to describe how level 1 and level 2 sleep studies are performed and identify the main elements which should be included in a sleep study report. And also be able to identify the main difference between level 1 and level 2 sleep studies and others called the limited channel sleep recordings. And you should be able to explain how to use a sleep diary and actigraphy to evaluate the patients with sleep complaints. And finally, to describe the difference between MSLT or multiple sleep latency test and MWT or maintenance of wakefulness test and how they are applied in clinical medicine. Okay. So I think with the sleep medicine investigations, it's no different to any other diagnostic tests that you actually order. Is that right? Are you able to see the slides? Because my husband comes to tell me that the slides are tiny.
I can see the slides quite easily.
Yes, I can see them.
Okay,
yeah.
All right. Maybe it's him who's got it wrong. Okay. All right. So the diagnostic values of all investigations actually depends on sensitivity and specificity of the test, as well as the pre-test probability of your patient sample. And all sleep medicine investigations should be used in conjunction with history and questionnaire information to try to deliver optimal diagnostic value. Now, sensitivity and specificity of questionnaires depends very much on the pretest probability of the patient population, and what you're seeing in the primary care it may be quite different from what I'm seeing in the sleep clinic. Okay. So we'll start with some OSA screening questionnaires. So most of the OSA screening questionnaires are actually highly sensitive, but they're not terribly specific, and therefore there's a high rate of false positives. And the sensitivity in the primary care population is lower, and this may mean that you may have the negative screening questionnaire does not rule out the OSA. So you can see here, with the Berlin questionnaire, if you use Berlin questionnaire, the sensitivity is about 82% and the specificity is about 39%. But whereas if you use stop bang with a cutoff of 3 or more, which is what the Medicare criteria uses. The sensitivity is 94%, but the specificity is only about 32%. Whereas if you use a stop band cutoff of more than 4, then the sensitivity decreases, but the specificity increases. And with OSA 50, the sensitivity is about 94%, and again, specificity is about 31%. What about Epworth Sleepiness Scale? Everyone talks about the Epworth Sleepiness Scale, but what we have to remember is the Epworth Sleepiness Scale is a subjective measure of daytime sleepiness, and it is what the patient feels, but that does not always necessarily correlate with objective sleepiness. And an Epworth Sleepiness Scale of 8 or more suggests at least mild daytime sleepiness, but it does not necessarily correlate well with measures of sleep apnea, such as the apnea-hypopnea index, and not all patients with obstructive sleep apnea will have symptoms of sleepiness. And
sorry. Carol, I might just interrupt. I think there is some comments in the chat saying that they can't see your slides properly, that you are on the main screen and the slides are tiny in the corner. Is there a way to change this?
Meera, I think so. Sometimes it's an issue with a specific attendee because of how they have set up their screen.
Okay.
I don't think so it's with everyone, because if that was the case, a lot of people would have highlighted that.
Okay, so maybe those that are commenting just need to change their own.
A lot of people can. I think so. There's sometimes some will have an issue with their settings, but everyone else can see that, so we can continue the session.
Okay. Sorry, Carol.
And I can try to help on the back end to other. Thank you.
So what I was trying to say before is that the Epworth Sleepiness Scale is a subjective measure of sleepiness, and there are actually multiple causes of sleepiness beyond obstructive sleep apnea. So just because one has a high ESS, it doesn't necessarily equal OSA, and vice versa. So Epworth Sleepiness Scale is not suitable to be used alone as a screening tool to identify patients at high risk of sleep apnea. So what about sleep study? The gold standard for sleep study is an in-lab full polysomnography with a sleep technician in attendance throughout the night. And this is known as a type 1 sleep study. And the availability is limited. It is fairly labor intensive. And as a result of this, it becomes quite costly. So here I am trying to actually do a sleep study. And this is one of the rooms that we use to do our sleep study at RCM. And so when you do a type 1 sleep study, there's a range of signals that we use. So we have signals that includes EEG and EOG. We do chin ENG, which is down here. And then you have nasal pressure, which is usually in a set of nasal prongs that you wear on your face. And then there's chest and abdominal belts that measures respiratory movements. We have oximetry on the finger here, and there's usually a couple of sensors on the leg measuring leg EMG. And typically you would also have a position sensor as well as a continuous video monitoring. And then for those patients who we're suspecting hypoventilation, we can actually add a transcutaneous carbon dioxide monitoring. And the rules are you need to do at least 8 hours of monitoring. And this is an example of the recording that you will get from a type 1 sleep study. So here we have 3 EEG channels, 2 EOG channels, and this is a chin EMG channel here and ECG. And on the bottom here, we have the oximetry. And as you can see in this particular example, the oximetry actually varies quite significantly, and at times it goes into the 70s. This is the nasal flow channels that shows us whether the patient's breathing or not. And there are some good examples of apnea on this particular example, the chest and abdominal belts. And in our system, we also have a microphone, so you can actually hear, you can actually see how much snoring there is, and this patient is operating at around 80 decibels or more. We have a couple of channels of leg EMG, so that's been shown here, and then this is the position sensor. So these records are actually analyzed with manual scoring and stored. So one of our sleep scientists reads all these signals 30 seconds at a time, and it typically takes a couple of hours for sleep scientists to completely analyze the sleep study. And then once that's been done, then the interpretation and the preparation of a permanent report must be done by a qualified sleep physician with a personal review of the raw data from the original recording. And these are the Medicare rules for to allow a Medicare rebate for type 1 sleep study. What about type 2 sleep studies? Well, type 2 sleep studies are essentially the same as type 1 sleep studies in that it has similar recordings, and the equipment for type 2 sleep studies, according to Medicare benefit schedule, can be applied either by a sleep scientist or by a patient. And the MBS requirement requires at least 7 channels, which includes airflow, continuous EMG, continuous ECG, continuous EEG, EOG, oxygen saturation, and respiratory effort. And these investigations must be performed under supervision of a qualified sleep medicine physician and analysis by manual scoring, and then subsequently interpretation and report preparation by a qualified sleep medicine physician. But note that in the type 2 sleep study, the NBS requirement says you should have at least 7 channels, and it needs to include EEG channel, but it doesn't necessarily say how much EEG you have to record. Do you just have 1 lead, or do you have the three lead EEG or 6 lead EEG, which is often what many of the public hospital laboratories would perform. So what about what are some of the drawbacks with type 2 sleep study? So I like to actually encourage everyone to have a think about what you're trying to order here. So essentially the type of sleep studies you will order is influenced by your differential diagnosis. And then also have a look at your patient and think about, can they actually manage a home study? Who is actually performing the home study and applying the sensors? Do you know what sensors are actually being applied? And then subsequent to that, do you know who's actually reading the sleep study? And what are you going to do with the results if your suspected diagnosis is confirmed? And what information will actually be included in the report? And this is particularly important if the doctor that's seeing the patient isn't actually the one that's reading the study. So, and we have to remember type 2 sleep studies are done at home. There's no sleep scientist in attendance. So if you have a significant signal loss, that will mean that you have no diagnosis. And so, if you have a patient come in who is legally blind, are they going to be able to apply their own sensors? Something to think about. Those patients who have some degree of intellectual disability, are they going to be able to do that at home? Elderly patients with significant arthritis. So those are some of the things to consider. Now, the Medicare benefit schedule rules indicate that to do a type 2 sleep study, the patient must be referred by a medical practitioner or a consultant respiratory physician with a stop bang score of 3 or more, or OSA 50 or 5 or more, or high-risk Berlin questionnaire, and an Epworth sleepiness scale of more than 8. So you have to have a positive OSA screening questionnaire, as well as some degree of sleepiness. Otherwise, the patient must be evaluated by a professional attendance from a qualified sleep or respiratory physician. And the other issue with a type 2 sleep study is that this item number is only applicable once in any 12-month period. So if you have a patient who is legally blind and who did not actually apply the sensors properly, or the oximetry falls off in the middle of the night, and you don't have any oximetry data for the vast majority of the night, then you actually cannot come back and do that again, and you'll have to stick with results you have for the 12 months period. So picking the right test is actually quite important. And then what comes out eventually, and which will hopefully be sent to all of you, is a sleep study report. So with a sleep study report, these are some of the elements that I look for when I'm reading a sleep study report, because I don't just read sleep study reports that are produced by my own laboratory. I also get patients who turn up with their sleep study, and these are some of the things that I look at to try to decide, do I believe in these tests, and can I be certain that this is quality sleep study report that I'm happy to act on. And so the things I look for is to make sure that there's some degree of demographic information. So they have, when was the sleep study done? Is there height and weight of the patient at the time of the sleep study? And this is particularly important if you're looking at a sleep study that's more than 12 months old, over which time the patient may have gained or lost a substantial amount of weight. Has the sleep study actually been interpreted by a physician? How much sleep was actually recorded? Where is that? What is the apnea-hypopnea index? Also, what is the lowest oxygen saturation and the amount of time where the patient spent during sleep where the saturation is less than 90%. And this may give you an indication of how likely your patient might be hyperventilating. And the other thing, which is often in small print, but is just equally as important, is exactly the type of equipment that's being used, what montages are being measured, how many EEGs do they do, was there actually any signal loss, and also the criteria used to analyze the study. So I've just put up an example of a sleep study that we would do at ISCA, where we actually believe in full disclosure. So you'll find that our reports actually have quite a significant amount of information, some of which you may never read, but all of which are important for me, not only here and right now, but in 3-4 years' time when I'm reviewing the patient again. So in this study, we do try to include some medications, some medical history, a scientist report that tells us whether the signals are technically sound or not, a sleep physician report, and typically I like to include some recommendations of what I think would be appropriate management beyond this point. And then towards the end of the report, on page 4 is where a lot of the stuff about how the sleep study was done is buried. So here we use a Knox A1 device. This is a home study. We actually recorded 3 EEGs as well as all these other signals. And then we go on to talk a little bit about what are the definitions of the different types of sleep, what definitions of apneas and hypopneas we use, because that can actually dramatically change your apnea-hypopnea index, and not every laboratory uses the same criteria, and then the periodic limb movements. Now, sometimes in Canberra, you'll see a few patients who will come in with what they call sleep study, and in fact, it could be a type 3 or a type 4 sleep study. And these things, although they're called a sleep study, aren't really a sleep study in that it is limited channel monitoring. And most of the time, they do not have any electroencephalogram. And if you have no EEG, you can't actually determine whether your patient's awake or asleep. So you could just equally have a patient who uses one of these sort of devices, and if they wander around the house all night and have no sleep, then they're not going to have, your apnea-hypopnea index is going to be 0 because they're not going to stop breathing. But because you have never measured the amount of sleep, you are not going to be able to tell that. And they are known as a home sleep test in North America. Typically, you do 4 to 6 channels, and usually has a respiratory channel, some respiratory movements and oximetry. This one has a position sensor as well, and So these are actually available from some providers in Canberra, and some of the pharmacies are actually doing tests like these. The important thing to remember with these is if you have a very high clinical suspicion, but you get a negative test with these, then they do not rule out sleep apnea. And the signals that have come from these devices may or may not be reviewed by a sleep scientist. And sometimes it's just fed into a computer, which is a black box, and it generates a colorful report. And at the moment, there's no Medicare rebate. So therefore, the industry is unregulated. And then you have, here are some of the type 4 sleep studies. So these are truly limited channel monitoring. So usually 1 or 2 channels. This is an older ResMed apnea link. So this is actually a 2-channel monitoring. So it only monitors airflow and then has an oximetry. Sometimes some of them will include heart rate. And then these days, there are some really small monitoring devices. This one is now available in Australia for $150. I think they call Sunrise. And they actually measure the movement of your lower lip. And apparently, according to it, you can actually derive whether your patient has sleep apnea or not. But in general, it's considered to be a screening tool rather than a diagnostic tool. So what are some of the factors that you should consider before ordering a sleep study? So I think I divide these into patient-related factors and also sleep disorder-related factors. So have a think about your patient. Are they going to be able to manage with the type of sleep study that you're hoping to do? So these could include intellectual disability, neuromuscular disease. Do they have a severe physical disability? If things have fallen off, are they going to be able to put it back on? And have a think about home environment, noise levels, family interactions. And the other thing also that's quite important is if you're going to do a sleep study that's actually to be carried out at home, what's the distance they live from the sleep laboratory? Because if they're coming into the sleep laboratory and we're going to set them up with the equipment, the further away they live from the sleep laboratory and the more things they have to do before they can get home means the more likely you'll lose your signal. And then finally, patient preferences. Some patients do prefer to come in to the laboratory because they know that if things are going wrong, there's someone to help them out. And then the other thing to think about is what sleep disorder are you actually suspecting, and can the test ordered be, is that going to be able to diagnose what you're looking for? So say, for example, if you're looking for someone who has sleep-related hypoventilation, where their carbon dioxide level is going to go up during the night, you need a transcutaneous carbon dioxide monitor, and you cannot do that on a home study. So if you order a type 2 or type 3 sleep study, you're not going to be able to make that diagnosis. So these are some of the things to think about. So in general, it's considered that if you're looking for some of these diagnoses, including central sleep apnea, hypoventilation, heart failure, some neurological disorders, you can't really do these. They're probably not particularly suitable to be done at home. If you're looking for sleep-related movement disorder, or you're looking for parasomnias, you really need to have a video recording. Then these things are also not suitable to be done at home because you can't do video recording at home. Okay, so now we're going to move into some other things that we do apart from sleep studies. And this is something that I think all of you can actually do in your rooms. So this is called a sleep diary. A sleep diary is essentially a daily record of important sleep-related information. And this is just an example of a sleep diary. This particular one is produced by the American Academy of Sleep Medicine. If you search on the internet, there'll be plenty of different versions of more or less the same idea. So typically in a sleep diary, you are asking your patient to record bedtime, their wake up time, how long does it take for them to fall asleep, the number and the duration of sleep interruptions, as well as daytime naps. And also for some of the sleep diaries, it's also helpful to actually record the consumption of alcohol, caffeine, and tobacco. So for example, here they've got an example here. So this is this patient's put down Monday, which is a work day, and then they put an E when you exercise. So at 1 p.m. the patient had an exercise session, and then at 6 p.m. he then put down A, which is A is, I can't remember what A is now. A when he's drinking alcohol, so he's having a bit of alcohol with dinner, and then they put a shaded box if they're having a sleep. And then they went to bed at about 10 o'clock, so he put a line there. And then he took a while, and it wasn't until midnight that he fell asleep, and he woke up at 4 o'clock. And then again, at about 7 o'clock when he got up, had some breakfast with a bit of coffee. And typically you do a 2-week diary, and that gives you a better understanding of what a patient's sleep duration and the sleep pattern is. So this is an example of sleep diary use. So I'm going to do a poll in a minute about this particular sleep diary. So this is a guy who's 25 years of age, and he turned up in my room, and he complained of insomnia. And he says his main problem is that I cannot fall asleep after going to bed. And the question I have for you is this insomnia, and will you give him sleeping tablets? So I'm going to do an audience poll to see what you all think. Okay, 5 more seconds, and then we're going to talk a little bit more about it. Okay, so I've got 16 answers now, and about 81% of you said that they didn't think this is insomnia, and 88% decides that they don't want to give them sleeping tablets. So so let's talk a little bit about it. So this is a university student, and what you can actually see here in the weekends, he actually goes to bed pretty late. So 3 a.m. on Saturday and 1 a.m. on Sunday. And even when he went to bed, it took a considerable amount of time before he finally fell asleep at 5 o'clock and again at 4 a.m. During the week nights, he goes to bed at about midnight, but again doesn't actually fall asleep until 2 or 3 a.m. And then Friday, Saturday goes to bed much later in the weekend. So this is actually an example of someone who's got a delayed sleep phase syndrome. So this is typically the high school student or uni student where they've got a circadian clock that's running much later than the actual time clock. So even though they've gone to bed because everyone else in the family's gone to bed, their body clock is not ready to sleep. So they have a delayed sleep phase syndrome. And the treatment for delayed sleep phase syndrome is actually early morning light, and Dr. Peter Jones will be discussing a little bit more about the management of something like this in one of the later webinars. Okay, what about this one? So the questions are the same. So this is a 65-year-old man, and he also turned up and said, look, doctor, I've got insomnia. Can I have some sleeping tablets, please? So the question I have for you is this insomnia? And will you give him sleeping tablets? And let's give you all about 30 seconds to think about this. Okay, now can we share the results now? Do I go and poll to share? No. So I don't know whether you guys can actually see the results or not, but
yeah, they can see the results now.
Okay, yeah. So 87% of you said that this is not insomnia, and 93% says you will not give them sleeping tablets. So let's have a look at this. So this is a guy who's much older, and you can see he has a tendency to go to bed at 7, maybe 8 o'clock in the evening. And then he wakes up in the early hours of the morning. Some days he wakes up in the middle of the night and has difficulty falling asleep, but in general, he's awake somewhere around 3 to 4 o'clock in the morning, and then eventually get up at 6 o'clock. And he's complaining of not being able to sleep through the night. But I guess one of the things to think about, is it realistic to think people are going to go to bed at 7 and they're going to stay in bed until 6? That's 11 hours in bed altogether. So in fact, this guy is having a reasonable night of sleep, but he's actually sleeping for a reasonable number of hours. But the problem here is actually that his sleep phase is advanced, and his body clock is ready to go to bed really early, but and then he wakes up really early as well. And the treatment for a patient like this is actually early evening light, and Dr. Jones will talk a little bit more about it in one of the seminars. But the other thing also, which I don't know whether you noticed, is that this guy has a regular nap in the middle of the day as well. So, that may also mean that he doesn't need as much sleep at night. Okay. So, and I have some more fancy examples. So what about this one? So this is a school-age child with sleepiness in class, and he has a difficulty waking up in the morning. So you can actually see here that this is an example of a real sleep diary that was done over the Easter holidays, and then the child goes to school, and you can actually see that this child's sleep pattern, it does actually have a pattern to it, but what you can actually see is the bedtime goes progressively later and later, and it spans throughout the course of day or night. And there's some days where he just simply misses going to school altogether because he was sleeping. And then there are days where he's forced awake by parent and got really grumpy. So this sort of sleep history can often be really, really difficult to take, but once you actually see it in a sleep diary, the diagnosis becomes very obvious. This child has a non-24-hour sleep-wake disorder where his circadian rhythm is much longer than 24 hours. So as each day goes by, his sleep time actually is delayed by a few hours. Okay, I want to spend the last few minutes talking about other things that we can sometimes do. And this is actually available to all of you as well. You don't have to be a sleep physician to order something like this. So this is an example of actigraphy. So an actigraphy is a non-invasive technique, which is used to objectively assess the cycle of activity and rest and you can do that over several days to several weeks. And here are some examples of actigraphy watch. So essentially they are motion sensor, and some of them look just like a watch and can tell you the time, whereas others are pretty bland and don't have anything. And often these can have a light sensor, and then they do a recording, which when downloaded produces sort of like a graph of what the activity is like. And then you can actually see the light levels in the yellow. And then there's this period where there's relatively little activity, but on this day, he got up, I think, for a bit and turned on the lights. And so this is an objective way you can actually measure sleep and activity, sort of not too dissimilar to how you are using your sleep diary, but this is an objective measure is the main advantage with this type of measurements. Now, multiple sleep latency test. Multiple sleep latency test is often a tool that we use to actually try to make a diagnosis of something like narcolepsy or idiopathic hypersomnia, which Meera spoke about earlier in this talk. And this is usually performed after an overnight sleep study. And so your patient, if being sent for one of these tests, they will be in a sleep laboratory for one whole night as well as one whole day. So they spend the night sleeping, and where we will have a standard sleep study monitoring. And then once they get up in the mornings, they're given 5 scheduled opportunity to nap every 2 hours, and with the first nap starting 2 hours after wake time. So they will be here for the entire day, basically. And this is used for diagnosis of narcolepsy and idiopathic hypersomnia. And the American Academy of Sleep Medicine have quite sort of a detailed recommendation on the protocols for multiple sleep latency test. So in order for you to have a valid MSLT, you have to have documentation of adequate sleep for 2 weeks, either by sleep diary or actigraphy. You must treat all other sleep disorders, and the treatment efficacy and adherence needs to be confirmed. Multiple sleep latency tests should only be conducted when the patient's clinically stable. If they're using a CPAP machine, or if they're using a mandibular advancement splint for treatment of their obstructive sleep apnea, they should be used on the night before the multiple sleep latency test, as well as during the naps. And multiple sleep latency test should only proceed if you've had at least 6 hours of sleep on the night before the test. So if you end up in the morning and you've only got 340 minutes of sleep by EEG, then in theory, you should really proceed to MSLT, because the results will not be valid. Now, medications that are sedating, alerting, or REM sleep modulating needs to be stopped for at least 2 weeks before the multiple sleep latency test. And it's really important to have a good medication history that includes over-the-counter medications. And the physician should really discuss about tapering of the caffeine and withdrawal, with aim to have abstinence by the time of testing. And patients should be out of bed and not permitted to lie in bed or sleep between the trials. And finally, urinary toxicology screen needs to be employed to make sure that the multiple sleep latency tests are not confounded by inadvertent, intentional, or illicit medication or substance use. Maintenance of wakefulness test is a little bit different. So the main objective of this is to measure patients' alertness and or ability to stay awake. So these should be performed after the patient's major sleep period. And in Australia, the NBS criteria dictates that you have to do a level 1 sleep study before you do your MWT. And the patient should abstain from alcohol, cannabis, and other sedating agents on the day of the test. So MWT includes 4 40-minute wake trials, which are 2 hours apart, with the first trial beginning 1.5 to 3 hours after the termination of the preceding night's sleep. And the sleep rooms should be dimly lit, and the patient should be seated in bed or in a recliner chair with back and head comfortably supported. And the idea is they're supposed to try to stay awake, and each trial is terminated once the patient has 3 consecutive epochs of stage 1 sleep, or 1 epoch, which is 30 seconds of any other stage of sleep, or otherwise after 40 minutes. So this is typically used sometimes when you have a patient who is adamant they're not sleepy, they don't need to have treatment for their sleep disorders, and they want to keep a driver's license. You can sometimes this could be the sort of test that you can employ to try to decide whether they have any objective sleepiness. And again, the American Academy of Sleep Medicine suggests that you have to document that the patient has had adequate sleep by either sleep diary or actigraphy for 2 weeks before the testing. And the test should be conducted when the patient is clinically stable and any of the non-sleep disorders should be treated and well established and effective. And again, they should use their normal therapy on the night before multiple wakefulness test, maintenance of wakefulness test, and they should have a plan as far as use of prescription medicines are concerned. And if they're taking their chronic medications with things that may be alerting or sedating, then they should continue on a stable dose. And the ordering physician, in consultation with the patient, should clarify what constitutes acceptable caffeine consumption. So that's all the slides I have for you tonight. And if you have any questions, we'd be happy to take a look at them. And thank you so much for your attention.
Thank you, Carol, and thank you, Meera. And yes, there are quite a few questions, and I can see there's people have typed in questions that I was also thinking about. So keen to get on to hear your answers. So we'll start off with the first question, and it says, do you know if people insist on continuing driving with narcolepsy or symptomatic sleep apnea are covered by their insurance in the event of an accident? Thinking it can be hard to find a lever to motivate some patients to comply around driving restrictions.
So I'll start to answer, but Carol, please feel free to jump in if you have any other expertise in this area. I actually don't know 100% whether they're covered or not, and I tend to put the onus back on the patient. I tend to say, look, you have a condition that significantly increases your risk of motor vehicle accident, and you may not be covered by your insurance now that you have a clear diagnosis of that, and you need to clarify that with them. I think the hard thing about these conditions is that, yes, they certainly increase the risk of motor vehicle accidents, but it's every individual person's responsibility to ensure that they aren't excessively sleepy when they get behind a wheel. So that includes patients without these conditions who are just sleep deprived. So, it's our responsibility to not do an all-nighter and then drive for 7 hours. So I tend to put that onus back on the patient. I agree it can be very difficult to use a lever to force these patients to comply. And to be honest, the ones that really end up the only real way I think that you can is those patients who end up require in that category where they don't meet the criteria for an unconditional license, and then they are reliant on seeing a sleep physician and having their license signed off periodically. And to my experience is that the only patients that I tend to see in that category are patients with severe obstructive sleep apnea who are commercial drivers, or who own a private vehicle but might have had a motor vehicle accident, or those with narcolepsy. Carol, do you have anything else to add to that?
I guess the important thing here is the responsibility, or at least in the ACT and in New South Wales as well, to actually report to the RTA actually lies within the patient. So if you have a medical condition, it's not the doctor's responsibility to report, but our responsibility is to tell our patient that, look, you have a medical condition that requires you to report, and it's their responsibility to report. I don't know whether most of you probably know that in the ACT, there is also a fitness to drive clinic, which you can actually refer your patient to. So I try not to get into arguments over who is fit to drive. I say, look, these are not my rules. They are the RTA's rules. And if you have any questions about it and you don't agree with it, then we can always refer you to the fitness to drive clinic. So that's some of the things that I cannot use, because it's often quite hard, and you don't want to actually damage that patient clinician relationship, but because you want to actually keep your rapport and try to help them along so that they actually do the right thing at the end of the day. So those are some of the things that I do kind of I sort of think about. Now, if you actually look at the Osro's rules, it actually says that if you have a sleep disorder that predisposes you to sleepiness, and you have moderate to severe sleepiness, then you're not fit to hold an unconditional license. And the RTA's definition is actually an adverse sleepiness score of 16 or more.
So one of the attendees has kindly put up the link for the OSRoads and the 8.3 section that covers that. And there is a related question which you might be able to briefly answer about what exact conditions to be placed on driving license when micro sleeps can happen even during a short drive. I would have thought that that's, really they shouldn't be driving if they were having micro sleeps in a short drive.
Yes. So I sort of say to people that, look, if your eyelids are really heavy, then you shouldn't get behind the wheel at all. The risk of having a crash is dramatically increased. But, from my point of view, if they have sleep apnea and their Epworth is 16 or more, then I tell them that they do not fulfill the criteria according to the RTA. And it is my responsibility to inform them that they should refrain from driving until their sleep disorder is treated. And I just leave it at that. And I put it in writing and I send it to them and send it to their primary care physician as well.
Yeah. So next two questions are two questions I wanted to ask as well. So lots of patients come in with very sophisticated Apple Watch readings, which have oxygen, ECG, deep sleep, light sleep, REM sleep on them. Are these useful devices, or is it useful information?
The problem with consumer devices like these is they evolve so fast. And because they evolve so fast, by the time any research validating their findings comes out, they've all become obsolete. You'd be on the next 3 iterations of Apple Watches before the first one is, the results have come out. I think, they may help you to form your suspicion, but ultimately you need testing, and you need testing with a validated device would be my advice. I mean, what do you think, Meera?
Yeah, I agree. I think that they're helpful with the things I mentioned about sleep quantity. So they might just show you that the patient is chronically getting less sleep than they probably should. That sort of thing. But the specific things on oxygen saturation, I find particularly the REM sleep measurements can be quite inaccurate. I don't know how a watch can tell whether you're in REM sleep or not. But people get really fixated on it. Like, they're putting down all their problems to them not getting enough REM sleep based on their Apple Watch. So I agree with Carol that I think, it might help as a screening tool. It might help with some very broad information, but ultimately they need dedicated assessment.
And then there's another question here which I was also interested in about siestas. So in many cultures, siestas are quite normal, and so people do have daytime sleepiness because they have sleep after lunch. So the question is, what about siestas as a cause of loss of nighttime sleep? Are they a problem?
I actually don't necessarily think siestas a problem per se. It depends on what the issue is. I mean, if it does not interfere with your lifestyle, they're not complaining of sleep initiation or sleep insomnia as a problem, then no, it's not a problem. But if they're complaining of unable to fall asleep at night or unable to, stay asleep at night, then, I think you will find in the next webinar where Terry and David is going to talk about insomnia, that they would usually recommend consolidating all your bedtime into one single block and trying to achieve a better quality sleep.
Right. Yep.
Yeah, I was just going to say, sorry, I agree with that. And that sometimes it is just normalizing things for patients. Sometimes they've come in because they think that they should be sleeping until 6 or 7 a.m., even though because they get up at 4:30 every morning, but they have a nap in the day. And when you tell them, look, if that's not a problem for you, if you don't mind waking up at 5 a.m. and then having a nap later in the day, and that it fits in with your lifestyle, then go for it. What matters is how you feel, and if you feel well rested and that works for you, then that's not a problem. And some of them as well come in because their partners don't like that they wake up early, or that and sometimes just validating that is all they really want.
So what about the effects of ADHD medication on sleep and other medications?
Well, ADHD medications are typically stimulants, and stimulants does have some issues with nocturnal sleep. So typically, if you're going to take those medications, you want them to take it early. And I think, again, these patients who take stimulants, it's actually very important that they still allocate sufficient time to sleep. And these stimulants are not replacement for sleep, and that's very important.
Yeah, I had a patient today who is on ADHD medications and was also very tired, and we were talking about that, how ADHD, she may have sleep apnea, and how ADHD medications don't help with sleep apnea. So yeah, it's important to work out the sleep pathology or the sleep habits of people with even if they're on ADHD medications. So this might be covered in the insomnia webinar in February, but any comments about long-term impacts for people who chronically use sedating antihistamines? So I guess things like Restavit or doxylamine.
Do you want to talk about that, Meera? I was going to say that's a safer for Terry and David.
Yeah. I'd just say my experience is that they tend to stop working after a while, and then the patient just reports insomnia again. Is that how you feel, Carol?
Well, I don't generally recommend using.
Oh no, I tend not to recommend either.
And I think they do have a significant side effect profile, particularly in the older patients. So I mean, I'm adamant that when people come and see me, that the first line treatment for chronic insomnia is cognitive behavioral therapy for insomnia, which you'll learn a lot more about in the next webinar.
Yep. And then we've got two more questions, and we might wind it up there. So both of these questions, I think, wind back onto our previous question. So I might just read the last question first and then the second last question second. So there is historical evidence that we used to have a normal expected biphasic sleep pattern. Any comments about this in current society?
Not sure I understand the question.
So I think it's that we used to kind of sleep at night and then also sleep in the middle of the day, and that was the normal way we slept. And having a consolidated block all at night is a newer invention.
Well, I don't know if that's true, actually, because, I mean, if you actually think about it, we used to rise with when the sun comes up, and before the days of electric lighting, everyone went to bed when it got dark. So I don't know that we necessarily think having a nap in the middle of the day is always been normal.
Yep. Okay, so we'll just move on to the last question, and that comes back to insurance and sleep apnea, which we're also going to have a dedicated sleep apnea webinar, but it's also in relation to driving. The patients need to check insurance requirements. A patient was given a clearance by a surgeon after 6 weeks, but when they had an accident, the insurance said it only 3 months after. I'm not sure, not covered. What's the fine print for sleep disorders? I'm not sure if you would be able to add to that.
Yeah, I think the question's asking, is there a discrepancy between what a doctor would say and what the insurance would say? I think that's very hard for us to answer.
Yeah.
But and again, I think you just have to put the onus back onto the patient if for some reason they've actually lost a license because of a microsleep or a motor vehicle accident, and then they've commenced on treatment. I think that would be the only but typically my clinical practice is again, it comes down to symptoms. So if they're excessive daytime sleepiness, I'm comfortable that clinically that has resolved with appropriate treatment of obstructive sleep apnea and they're compliant with therapy, and I've got evidence that they're compliant with therapy. I don't see why they can't start driving straight away after they've demonstrated that. Carol?
Well, I typically do not. I typically tell the patients that you can drive if they can show me that they're using their device. Their device shows that they're adequately controlled. They don't have a significant sleepiness. By measurement of Epworth sleepiness scale, and they're using the device for at least 4 hours per night every night for at least 30 days, then I'm happy to tell them to return to driving. But I guess we can't tell what are the fine prints for the insurance requirements, and may actually differ from company to company. I'm not sure. I guess this is one of the things we never look at when we take out insurance. Do you know what an insurance company says about your policy?
Yeah, no. Okay, well, it's almost 8:30 there, so apologies that there's been a few more comments in the Q&A box, but we might just have to wrap it up. So apologies if we haven't got to your questions. But thank you very, very much, Meera and Carol. That was really useful. And it's a little taster for what's to come. So I would encourage you all to attend the further sleep webinar series. I really personally think that so much of primary healthcare is about sleep. And so learning how to help patients to sleep better is really critical for all of us. We're going to send out an evaluation survey, so please fill them in, and we'll send out a certificate of attendance so you can upload your CPD points, so 1.5 hours for educational activities. And the slides will be sent out to attendees, and we will put the recording on our Capital Health Network YouTube page, which is free for anyone to watch. So thank you very much again, Meera and Carol, and we'll see you all in February for the insomnia webinar. Okay, thank you. Good night.
Thanks, bye.